and we'll get started. Okay. It's great that all of you can attend, and it's great to see we've got quite a few people already attending. I'll just give it till 2 minutes past and then we'll get started. Okay. All right then, I think we're going to get started now. So, hi everyone, my name is Stephanie Garty. I am the clinical and pharmacy clinical fellow at NHSX this year. So I'll be hosting this masterclass session. It's the last masterclass session of the year, so December. We're going to have two speakers today. So our first speaker is Claire Davis from Gateshead NHS Foundation Trust, who will be talking about electronic insulin prescribing. And then we have Rob Gooch from NHSX, our technical architect, talking about the dosing tax and just an update on the information standards notice that was published earlier this year. So let me just introduce our first speaker. So like I said, it's Claire Davis. She is a diabetes and endocrinology specialist pharmacist at Gateshead NHS, Gateshead Health NHS Foundation Trust up in the northeast of England. And I'll let her present, and then we'll ask some questions afterwards. So if you have any questions, please put them in the chat and we'll aim to answer as much as we can during this session. Okay, I'll hand over to Claire now.
Hi, I'm Claire Davis. So thanks for the introduction, Steph. So I'm going to pop my slides up and I'm going to minimize myself. So just so you know I'm here, but because otherwise I can't see myself, which is a bit disconcerting. Okay, so I am the diabetes and endocrinology specialist pharmacist at Gateshead, and I've been asked today to present on e-prescribing for insulin as relation to some work we've been doing nationally around this. I'm going to give you a bit of facts and figures and kind of where we are now. I'm going to whiz through that. And a bit of a chat about errors and pitfalls, and then some thoughts about human factors before I talk about some systems, solutions, and the future. I'm not going to give you the answers today. I don't think I have them all, and I will freely admit that. But hopefully it'll prompt some discussion, some thoughts that you might want to take back to your own organisations about how you prescribe insulin in whatever system you're using. So where are we at the minute with insulin? Well, 1 in 6 people in your hospital at any one time can have diabetes, and in some places that's up to 1/4 of beds. And I find this infographic on the right-hand side here really striking, that people with diabetes spend about 3 hours a year with a healthcare professional. That rises if you have a hospital admission, but it's still not a huge amount of time, yet it's a really important interaction that we have. And you may have seen these headlines before, but this is a few years ago that over 250,000 people with diabetes had an inpatient hospital medication error. And I'll talk about where that data has come from. And just last year, sadly, a person with diabetes in Lincolnshire died after an overdose of their insulin. So nearly 1 in 3 people with diabetes will have a medication error during their stay, and 2/5 of people treated with insulin will have an insulin error during their stay. So if you're a person with diabetes, or your family have diabetes, or you're treated with insulin, this is horrifying. I will freely admit that this is horrifying. So we know this is high risk. It's something we really need to be aware of about how we can make this safer for people. So what's happened nationally is where I'm going to start. So there's some national publications, and I've just popped a few of them on the slide here, and these have come from the MPSA, MHRA, and a few other places, and you'll notice these go back as far as 2011, and you might be looking at this thinking, well, oh my goodness, where have we got to with insulin? It's not getting any better if this is the case, and if this is how much we've got how many alerts we've got, what do we do? But really, I think this is just a reflection of how complicated insulin has become over recent years and how we've become more aware of the risks with insulin, especially with high strength products, biosimilar products, and so on and so forth. So what about national data? So I'm just going to really quickly flick through the national data and I'll show you where you can find this, or tell you where you can find this. So the NADIA might be something you're aware of. That's the National Diabetes Inpatient Audit. It happens annually, apart from last year, for obvious reason. It's a one-day snapshot in September where trusts can audit themselves and their diabetes inpatient care, and it gets benchmarked across the country. It measures inpatient care, so did we minimise risk? Was there any harm from the stay, and what was the patient experience? And that data is freely accessible. It's all on the NHS digital website. You can get an overall report, but what might be even more interesting to you is you can also get a hospital level analysis, and that will pitch your trust against every other trust in the country. And you can see whether you've improved year on year. You can see where you've improved, where you've maybe not improved, and what other places around you are doing as well, which is really helpful. So 2019, that's the last year we have data for. Overall, since 2010, we've seen a reduction in medication errors, which is fabulous, absolutely fabulous. We should be seeing that. That is great, and we should be seeing from the treetops about that. That's fabulous news. However, there's a few things remain unchanged, and that includes severe hypo episodes, hospital-acquired DK, and hospital-acquired HHS. And the take-home point from NADIA in 2019 really was that medication errors remain far too high, even in those who've adopted health technologies. So that's just that final comment there, and that includes electronic prescribing. So we've seen improvements, but stuff has still stayed a bit too high, unfortunately. And if you look at the breakdown report, which I haven't put in these slides for time, you can break this down into medication error, insulin error, and type of error as well. So it does really drill down your detail. There's also the Get It Right First Time reports, also known as GIRFT, and this has been done in a range of areas. It's a surgery background, this report. It's due to variation in care. They want to look into if there's any variation. There's a data pack for every trust who was visited. So 108 of the 140 trusts in the country were visited with regards to their diabetes care. And again, there's an overall report accessible on the internet for GIRFT. Just search GIRFT diabetes and you'll find it. It's got multiple sections. Again, if your trust was visited, you'll be able to get your own trust report, which is far more detailed, includes all your data, because a lot of data had to go to GIRFT before they visited. But there's a bit that is really important for us on this webinar today, and that is that there's an entire section on reducing insulin errors. So GIRFT mentioned that insulin error is the third most common cause of death or severe patient harm from medication error in the UK. It remains the most day-text drug. And it's certainly, for most trusts, I believe that will be the case. If it's not your most day-text drug, fabulous, or do you not know what your errors are, which is the other problem, I would say. Almost 40%, GIRFT hark back to that statement from earlier, have an error during their stay. And less than half of people with insulin have a good diabetes day. So it's not just about getting that insulin right, it's then about controlling that insulin and making sure that we give good diabetes control while you're an inpatient. So the GIRFT recommendation was that everybody involved in insulin, any section of insulin, should have training. So any healthcare professional for dispensing, prescribing, or administration, and that should be appropriate to their level of responsibility. So bear in mind, a blanket ESR insulin module for safety probably does not meet this criteria, because it needs to be appropriate for your level of responsibility, and that should include assessment of competency. One thing I will add, and we're really big on at Gateshead, as we talked about this yesterday in our Diabetes Safety Board, training and education is brilliant. It can do so much. However, in conjunction with system safety and system appropriate solutions, because training will only do so much and the system should be there to support you as well. And I will come on to that today. So when I was putting this together, that leads nicely onto this quote. I found this quote that says, "You do not rise to the level of your goals, you fall to the level of your systems." I know everyone today is using different systems, but hopefully we'll probably all resonate with this a little bit. How many times have you asked, can a system do this? Can it do this? Can it do this? I'd love it to do this. And you've been told absolutely no way, it won't do that. And the door's slammed shut in your face, and therefore as a result, instead of rising to the level you want to, you fall to the level of what is possible. So is there a perfect system? I'll be honest, I don't think there is, and I think we all probably know that, especially with e-prescribing and especially with something as complex as insulin. What we do have to do is think about balancing our risks. What you certainly don't want to do is react to one error and replace it with another error that could potentially be more dangerous. So I'm going to talk about some risks today and some strategies we've put in place that you may or may not find helpful. So before we talk about that and how you make things better, the first thing you have to be aware of what are the errors and what are the risks with insulin and e-prescribing. The first is probably the drug names. They sound alike and they look alike, and I will demonstrate that on my next slide. But if you're a diabetes specialist like myself, it's obvious that M3 and Humulin I are different things. Likewise, Humulin Mix and 50 versus Humulin Mix 25. However, if it's 3 o'clock in the morning and you're on your first ever night shift, that is probably not obvious to you, and that is understandable that that is not obvious to you. Insulin doesn't really help itself, unlike if you had somebody on a statin. Torvastatin 20, straightforward, it's not open to interpretation. So that is your first big stumbling block, is how you make your drugs clear on your prescribing system that they sound the same, they look the same, but they are very much different. Dosage is a huge problem. So dosage records, I used that example of a torvastatin 20, it depends where you work, but most places will have an easy way of finding out what medicine someone's on. So we up in the Northeast have Great North Care record. It's fab, I can get access to your letters, your mental health record, your drugs that you're getting from a different hospital, everything in one handy place. And that is straightforward for tablets that aren't open to interpretation. However, for insulin, it is very rare to find a dosage record on a GP system. And if you do, I will always tell people to take that with a pinch of salt because it changes so frequently. As a result, though, you introduce two potential risks. One is that you end up with the wrong dose prescribed because we haven't got a dose recorded anywhere, or worse, it's completely omitted because you don't know what it is and therefore you don't prescribe it. So that's another error. What we've done at Gateshead, we found that was a problem, is we've developed a process, we've developed a quick protocol that says if you don't know what dose someone is on overnight, here's a way to keep them safe as a weight-based calculation. So you can calculate the dose that person would be safe on because you know they're not insulin naive. You can put a message on the prescribing system to the pharmacist for the morning saying, this is what I've done, please will you check this? And it will keep that person safe and out of DKA, because you'll have seen on those earlier slides that DKAs in hospital have not changed from the NADIA data. So that was one of the safety nets we put in, not an e-prescribing solution, but a way of saying, we know you'll probably know what insulin someone's on, but you might not know their dose. And then timing is a really common thing that comes up in NADIA every year, that insulin's not given at the right time. So biphasic insulins that should be with food end up getting prescribed at night, and so on and so forth. So this is a visual prompt that we use at my trust. This is to help, firstly, for people with diabetes who are admitted who are struggling to communicate or describe their pen and we don't know what it is. And also as a prompt for any of our staff involved in administration of insulin to make them think about what insulin they're giving at the right time and to act as a bit of a guide to them as they get something out of our cabinet. Have they got the right insulin in their hand? It's not perfect, and it doesn't cover everything, I will say that. But the other thing I would add is if you're a brand new junior doctor or nurse practitioner or pharmacist, no wonder this is overwhelming and no wonder we get it wrong, because look at how similar all those products look like. So the other thing I'm just going to quickly touch on is high strength insulins, which have come to the fore in the past 5 or 6 years. So everything was previously 100 units per mil, and higher strengths have increased in recent years, and that means we can give a reduced volume. Now, personally, if we prescribe the wrong strength, to me, that is not a huge problem because we should be dialing that up via a pen. We should be still giving the right dose, but there is a risk of confusion, so we need to take care. And that's Tresiba and Humulog, which both come in multiple strengths, and then Humulin R, which also comes in, which is a 500 unit per mil insulin. For those who work in specialist centres, you might be familiar with this. There's no maths needed in the dial-in units, so you should reduce that risk. But if people don't know this, and they don't know that some of the pens dial in 2s, 3s or 5s, it's very easy for the wrong dose to get prescribed, and then it's not possible to administer either. So what about human factors in this e-prescribing, and particularly in e-prescribing of insulin? Well, the first thing to bear in mind is anybody can have a slip or a lapse while you're prescribing. So if you're in your system, you pick Humulin M3 for your first dose, you get distracted, you're asked for some paracetamol for bed T and bed 15, and you go back in and then you prescribe Humulin I by accident. And that is added to by a lack of familiarity or awareness of the drug and the risk of those different drugs. Fatigue and environment have to play a part. We have all had a really tough year, couple of years working in the NHS, and that doesn't seem to be getting any easier. So there's workload fatigue, including noise and distractions, but there's also alert fatigue, and I think this is really important as we think about electronic prescribing systems and insulin, not to be careful about alert fatigue. So we put alerts on our system for some things, but sometimes I will freely admit as a prescriber, I don't always read them. I click past them. I'm prescribing a lot, I'm busy. If I click past them, how do I expect anyone else in the MDT to read that alert? It's there as a barrier, but it's about putting alerts in carefully and not overdoing it, especially if you're worried about. The other thing we sometimes find is when we investigate our errors or our problems, the most common time someone makes a mistake is the end of night shift, 8 o'clock in the morning, the last person they've seen before they go home. So we have to be aware of that. Fatigue plays a massive part. So one thing we've done at Gateshead, which we've found really, really effective, is making sure that any of our errors are investigated in a personal and individualized approach. So any insulin-related prescribing error will come to me, and I will speak to that prescriber one-on-one about what happened, why did it happen, talk me through what happened. I want to understand what was going on at the time. And there's been a lot of talk in the NHS over the past 2 years from Michael West about compassionate leadership and how you get more from your staff if you lead in a compassionate manner. And I think this also feeds into error investigation as well. The key thing I will say is the system is not always the problem, but neither is it always the solution. And it's key to be aware of that. So I will ask people to walk me through what they did when they were seeing that person. How did you find the drug on the system? How did you prescribe it? Talk me through what you were doing. But I'm keen that the system should not make the situation worse, and it certainly shouldn't make it more likely for someone to make a mistake. So I also do the substitution test. If someone else was in the same position, could they have made the same mistake? And if so, you need to look at system solutions. So that leads me nicely onto general prescribing on e-prescribing. I'm going to whiz through some tips and things we have done and you might find helpful. So when someone comes into hospital, I think this is what we think happens. So the person's admitted, we identify they use insulin, we know we need to prescribe it, and then all of a sudden we have to think about type and dose and device and strength. We go to prescribe it, we find the insulin, gets prescribed and it gets administered, jobs are good. And what I think actually happens from investigating incidents is that there's so much to think about with insulin is that it all happens at once. And as a result, it's unbelievably confusing. And you increase that risk of making a mistake. There's no set standards for insulin prescribing across the UK, which makes it even more difficult. I know those among you who work in EPMA will say DMND is coming, that will help. It might, but it might not. Just in act of full disclosure, we use Careflow Medicines Management at Gateshead, previously known as WellSky or Jack. They have seen this presentation and they are working with us on some national works. There's a national working group going on, and I must say that has been really, really eye-opening for them to work with us as clinicians for what we need as well as what they can provide us with as well. So what have we done? We have to think, do you include brand or do you include generic, or do you include both when it comes to insulin name? Do you include device? Do you include strength? And there's all these things to think about, and it all depends on how your system works and what you feel is going to be beneficial for your prescribers and the users of your system. What we have gone for is a standard format across all our platforms and across all our clinical areas. So our prescribing system, our dispensing system, and our Omnicell system, so our medicines cabinets, all display insulin in exactly the same way, and that is brand name, brackets generic name, then device, and strength only on the high strengths, and that means it's consistent for transfer of care as well. There's a few things you can look at that you might be able to do on your systems. The first is fixing your fields. So units, for example, one of the biggest errors that vanished when Nadia was put in was an awareness that people were having a lot of errors with people miswriting units or abbreviating units. That has vanished when ePMA has gone in, because you can fix that field, which is lovely. You can also sometimes fix your fields for biphasic insulins on your system. So do you want to force it to prompt you to prescribe with meals? But be aware that one size does not fit all, and you may still sometimes need to adapt that depending on your patient. Can you prioritize or non-prioritize your drug files? You saw from that chart there are hundreds of insulins available. Are there things you don't use in your area? They're non-formulary or porcine insulins, for example. Can you move them so you're less likely to select them and therefore less likely to have an error? One thing I would say about orders of lists is be careful with the names. So if you list everything by brand name, you'll find that Humulin I stands next to Humulin M3, which also sits next to Humulin S, which are very, very different insulins. They work in very different ways. So if you select the wrong one there, you will end up with potentially a significant error because someone will get the wrong type of insulin. So it's about balancing one risk against another. Prescribing alerts, which I've briefly touched upon. So we have opted for alerts purely on our high strength drugs and our porcine and our bovine insulins to act as a barrier and a double check step to say, are you sure this is what you want? We haven't put it on everything. We opted for those files because we felt that was where the highest risk was, and because we felt like if people only saw it on certain files, it might stop them and make them check. And that was the feedback from our medical team as well. And then think about your supply process. So is it clear for your dispensary staff, for your ward staff, what they are getting out, what they are administering and when they're giving it? And that also feeds into primary care. So do they know what you've given and why you've given it? What we've done as well is made sure our drug library for our electronic prescribing system also mimics our drug library in our letters. So it's clear what type of insulin someone is on. Okay, I'm going to have to fly through the next bit. So there's a few things that make insulin more tricky, one of which is PRN dosing and individualized regimes. They're tricky to accommodate. It's hard sometimes for understanding, both for staff and people living with diabetes, how we've prescribed that on their system if they use 1 unit for so many grams of carbohydrate. This is not something we have got right yet, I will freely admit that. What I would say to you is think, what do you want from your system? What do you want it to do? What do you want it to tell you? And as my perspective, I want to be able to tell how much insulin a person has had, because if they become unwell, I need to put IV insulin up for any reason, I need to suspend their insulin, I need to know how much they've been having. So it's important to have clear documentation. Can you use free text notes? Can you use dose ranges? And is it easy for your nursing staff to sign off what has been given so you can get a record of what someone has had? To me, that's the priority. So don't overcomplicate it. Think what you want from your system. And the same goes for self-administration to a point. So Gerft said that all trusts need the ability to allow people with diabetes to self-administer and self-manage their diabetes. Sounds straightforward, not that straightforward. There's more than that to think about. So when I think about self-administration and self-management, there's a few thoughts that come to mind. The first is, how do you record and document that that's what that person is doing? It needs to be clear that they are self-administering. How do you build that into your system and your process? So on admission, is it part of MedsRec that you think, is this person self-administering? How do you review that as the admission goes on? So someone can come in able to self-administer, but their clinical status can change. How do we facilitate that? And vice versa. You might come in not able to self-administer, but you improve, and therefore you want that control back. And that again ties into variable dosing, because self-administration would also need to be able to facilitate adjusting your dose. So the world of digital is coming to diabetes. For anyone who's seen the NICE update, it looks like almost everyone is going to get technology from next year. How do we facilitate that on an electronic prescribing system? Pumps, technology, continuous glucose monitoring, flash glucose monitoring. Again, just think, what do you want your prescribing system to tell you? And try not to overcomplicate it. So for me, these are the thoughts we've been having. I want to know what technology a person is on, so I can tell at a glance from their drug chart what they're using. And if they're on a pump, I want to know their total daily dose of insulin for the same reasons I mentioned earlier. So how much insulin have they been using? What type is that? What type of pump that is? and what device they're using to fill that pump. I might want the rate, but then again, that comes back into not overcomplicating it. People can change their rate every half an hour, every 15 minutes. Try and be realistic what you think you can achieve. And what about infusions? I'm going to quickly fly through infusions and feeding regimes. So IV insulin is incredibly high risk. We all know this. It's also hard to facilitate on an electronic system. We have variable rate infusions. Those who work in the Northeast or in Hull also have GKI infusions. I think the key again is documentation and enabling that as part of your system. Can you tell when a rate changed and why it changed? And that might not be due to a prescribing system intervention. So if it's changed due to a capillary blood glucose, you're not going to know that's changed, but it might have changed because you've prescribed something different. You've restarted their basal insulin, for example. It might be due to a clinical intervention, as I say. So it needs to be obvious for both clinical interventions and prescribing interventions why rates have changed. When somebody ate, when they last had their insulin, and when that infusion came down is really important as well. So clear documentation. Feeds and insulin cause a huge range of problems and thoughts to go ahead with. So the first is if you have a feed with no insulin, there's a risk of hyperglycemia. If you have insulin and no feed, there's the reverse risk, hypoglycemia. So, and the timing of this can be non-standard. So your insulin needs to be given usually with your feed. Some trusts feed overnight, some trusts feed first thing in the morning. Some patients have their feed at mid-morning, mid-lunch. So it's facilitating that non-standard timing and making clear that that insulin needs to run with that feed. Can you annotate? Yeah.
I just think we've got a couple of minutes left. Would you be able to wrap up, please?
Of course, of course. So the final thing I would say is you can use some reports to inform your solutions. So we have safety features built in to flag for us if people are prescribed a unit or 100 units. And you can integrate that with clinical decision support checking, so dose checking for high strengths, weight-based doses, and safety features as well. So I'll finish with this slide, and we've been working with WellSky, and they have been great about thinking about our wish list. I would challenge you to instead of not rising to the level of your systems, your goals, rise to the level of your goals, accompanied by the level of your systems. And what if your goals raise the level of your systems? If you've got any questions about ePrescribing, I know that is a whiz through insulin. Please pop them in the chat and I'll stay on the call and I'll answer those as best I can.
That's great. Thanks, Claire. That was a really good presentation. There's a couple of things that I just wanted to pick up on. You mentioned something about DM&D and it not being, you don't necessarily think it's suitable, but with DM&D it allows us to have generic, it allows in secondary care to be able to look at the dose and look at generic and brand prescribing. Do you think that's a way of going forward and moving forward? Because that's with the standards that should also help across the system.
Yeah, I totally think it is, and I think we need consistency, and currently we have so many systems that do so much. So if DM&D can keep us all the same, I think that will definitely improve patient care. The risk is going to be doses. Yeah. How do we keep that dosing clear?
Yeah, and I think with DM&D, if everyone adopts DM&D and as well as NOMED, I think that should also be able to help in standardization, and with the introduction of dosing tax, which Rob is going to talk about, that should also help as well, and with standardizing doses across the system. And I think there's a couple of questions regarding some of your errors from the beginning. With regards to insulin errors, are they necessarily separated into IT mediated? Do you separate them into what's caused by the system and what's caused by human error?
Yeah, so I talk to the person involved because you can't tell from a Datatex report whether it was a system error or a human error. And I want to know what process that person followed, because there are multiple ways of going through insulin prescribing on one system. I also separate it by location it happened, time of day it happened, what shift you were on when it happened, was it the start or the end of your shift, what was the workload like when that happened, and then the type of error as well. So was it related to a DKA or a hospital emergency or prescribing on admission or administration, and those trends then inform what we do. So that's what informed us to put certain safety nets into our system.
Okay, Okay, I think there's probably some more questions, but I'm looking at the time, so I'm going to go on to our next speaker. Yeah, I'll go on to our next speaker. But if anyone has any more questions for Claire, please feel free to put them in the chat, and Claire will answer as we go along. So I'm going to introduce Rob Gooch, who is the technical architect at NHSX working in the digital medicines team, and he's going to present about dosing tax.
Thanks, Stephanie. And Stephanie, have a look at the questions, and also Claire, have a look at the questions that are in that have been submitted. There was lots of questions submitted during your presentation there, and that was really good. So thank you. Hi, Rob Gooch, technical architect from NHSX. Giving you an overview of some of the work that's been going on over the last 6 months within the whole medicines interoperability space. But the first thing is actually going to quickly hand back to Steph just to do this first question. Steph, are you okay? You just pick up this first question, and then I'll pick up after that.
Yeah. So I'm helping Rob. So we're going to be asking about the information standards that was published earlier this year. So we wanted everyone, if possible, if you can go onto menti.com and then input the code 12731566. And if you can answer the first question, which is, do you know what's expected of you to implement the ISN, the information standards? If you can't access the Menti, please put your answer in the chat, or you can email Sarah Black on sarah.black@ahsn-nenc.org.uk. Okay, and then after we get some answers, we'll move on to Rob's presentation.
What I could do is, as people are going on to that, I could start going through the slides, because people can hopefully do things in parallel. Or do you want to have a view of the answer before we move on? You're on mute.
Rob, if you just move on, that would be great.
Okay, I will move on. So, right, some of you would have seen me back in March early in this year as I presented to the same group around the fire standards and around dosing. So you'd have seen back in March our mission statement for this work to create fully interoperable computable medicine and prescription information across the NHS, enabling seamless transfer of care and ultimately a patient-centered consolidated medication record. That's still our challenge, that's still our mission. And back in March, I shared with you stuff that's you'll be able to go back and find this. Told you about this standard called HL7 Fire and why we are choosing to use it. The specific challenge around machine readable dosing instructions, and just in the bottom left of the bottom right of the slide there is one of the slides that we presented back in March. And where will this fire standard be used for meds interoperability? So if you didn't see that back in March, in your own time, go back and look at that presentation, or resurrect that from your mind. So what we've done in the last 6 months since then is we've started putting the puzzle pieces together. So to deliver this ecosystem where the system suppliers have the tools they need to give you the functionality you need, there's the building blocks on the left. There's the the specific bits of software, the APIs, the way that applications speak to each other, and then there's the implementation guidance that pulls it all together. So that's a combination of things that come under the scope of standards, things that come under the scope of implementation guidance, and we've been busy doing both of those over the last 6 months. That's all culminated in this information standards notice that went out in October 21 for a deadline of compliance of March 2023. So through engagement with various stakeholders, through providing various supporting information, what we have is an ISN that's been published, and there's links on this slide to go to that ISN to lay out the standards that need to be used for medicines-related use cases going forward. So what I want to do in this presentation is whiz through some of that documentation so that you can, when you go to it in your own time, you know what to expect, you know where to look, and it will just make it easier to walk through. So this is where I'll just change my screen to
Hi everyone, I think we have a problem with the system not displaying, and Rob's just been thrown out, unfortunately, and not able to get back in at the moment. So huge apologies for that, not quite sure what's happened there. Essentially, the Information Standards Notice, which was published in October, requires that the NHS are compliant with the standard by March 23, as Rob has said. And there is a significant amount of implementation guidance available now, which walks you through all the information that you need to know so that you will be able to implement the standard, or the suppliers who provide your systems will be able to do that. Essentially, any message which moves medication prescription information around the system will be required to be compliant with this standard by 2023. So any work that you're doing to look to bring GP information in, for example, to support medicines reconciliation on admission, same on discharge to supply information back out to GPs, information going into shared medication or shared records, all of it will need to be compliant with the standard. That will allow you to reuse the information. So instead of just being able to view information from other systems, it will be in a fully structured format, so you will be able to actually reuse it to support the work that you're going to need to do if you want to automate things like medicines reconciliation. And as Claire said earlier, with things like insulin, rather than having to manually translate and potentially increase error rates, you'll be able to reuse information, for example, from a GP system, so that you just say yes or no in terms of whether you want to re-prescribe it, hopefully reducing the number of times by which things are proven challenging. So all of that information is there. We'll make sure that the slides are shared with you at the end of the call. And please do go and have a look, because it's going to be incredibly important that you understand what's there. As Rob said, the suppliers are all aware of this. They've all been informed. They've all been supporting the work over the last 12 months to actually move this forward and to ensure that we can actually deliver a standard, or we have delivered a standard which is implementable. So now I'm going to hand back to Stephanie, and I'm hoping that she can pick up the other couple of questions that there are around the Mentimeter. Rob, is there anything that you wanted to add now that you're back, or anything that you wanted to pick up? Rob, you're on mute. We still can't hear you, unfortunately. Not quite sure what's going on, but we can't hear you.
I think, Rob, I might just take over from now and just ask a couple of questions from the Menti. I don't know if Rob, if you're screen sharing, can you go on to the next question for me? And so we're going to continue the Menti questions. Okay, and I'm just going to share my screen. Sorry about this. We're having a technical hitch. And I'll just share my screen in a minute. Okay, so I think the second question. Sorry about this. Let me just share my screen. Can everyone see that?
Steph, nothing is coming up. I think given the time and the pressure that everybody's under in terms of work, I wonder if what we do is we call it a day, unless anybody's got any specific questions that they want to put into the chat. I suspect we've lost a load of other people as well. So I suggest that everybody who's on the call, this is clearly going to be important moving forward. We would love to hear from you. Clearly, there are a lot of people that don't know about the ISN or understand about dose syntax, given the responses that we had at the beginning. The Mentimeter is there. It would be phenomenally helpful if you were able to actually go into it and give us some feedback. Obviously, if you're not sure about the ISN, you're not going to be able to answer question 2. Question 3, how can we help with adoption implementation of the ISN? And providing your contact details will be incredibly important. So if you're able to actually go into the Menti and have a look at it and respond to the 3 questions that are there, that would be incredibly helpful. So I guess we'll leave the call open for those who are still able to stay with us, and we'll pull the answers up as they come. But huge apologies, for some reason we seem to be having some problems today with GoTo, with people being kicked out. Steph, I'll leave it with you.
Yeah, okay, so let's go through some of the questions that we've had. Thank you, Anne. And so I'll go back to Claire's presentation and some of the questions, if Claire can come back on the call. And some of the questions were regarding if they could have your contact details, Claire, if you could put that in the chat.
I'm working my way through the massive raft of questions. So firstly, thank you for everyone's engagement. There is so much. I've answered some of the really quick ones. So my email address is claire.davis, spelt Davies, Davies, claire.davies62@nhs.net. So ping me anything you like, just give me some time, I will get back to you. I'm also on Twitter @ClarieRivs, which is an even faster way to get in touch with me because it will ping my phone. So yes, anybody who wants anything, please get in touch. More than happy to share. It's really useful to know what other people are doing as well, to not reinvent the wheel. So yes, anybody who wants to get in touch, feel free.
Okay, I don't know if you've answered this one already. Reviewing your selection errors, and have you amended your drug files to try and reduce the errors? Do you have the name, do you have the description of the insulin in the drug file?
Yeah, so I've answered that from Anna already, but just because I think that's a lot, I will explain. So we found one of our most common errors was Humulin I versus Humulin M3, and they sat next to each other on our list. So we have adjusted them so they don't sit next to each other. They're very much distinct now, and that has taken that error away. It's vanished because all of a sudden you can't click one, you'll end up with something completely different, which we don't really use very much.
Okay.
We haven't got the type of insulin in the file, and the reason we haven't got the type of insulin in the file is we ran out of characters, and it's about, if it's going to hang off the end of your file and cause more confusion, don't put it on. But the drugs that have generic names in them, though, because we have generic name included, anything that is biphasic has the word biphasic in it, which therefore acts as a prompt that that is biphasic. So we've kind of done a bit of a halfway house, but I know certain trusts around the country have put have put their names into their electronic prescribing system. So it all depends on what your system will allow you to do.
Okay. Somebody asked about with CMM, well, Sky, are you able to prescribe ranges, obviously because people have different systems?
Yeah, so I was just replying to that actually. So the only way on a CMM you can put a range in is if you prescribe something as PRN, which is not perfect because it means you have to put the drug in as PRN when it might be a regular insulin at night. So I tend not to do that. I will do it for like Nova Rapid with meals, and if it's PRN, then the nursing staff can sign off anything up to what you put. So you need to put the highest dose the person may have. If it's PRN, you can also write a range on as well, but it only works for PRN drugs rather than regulars, which is a little bit of a gap that we are working with CMM to address.
Okay, someone asked about how robust or comprehensive is the training and education about insulin prescribing? Is it mandatory?
Yeah, so
do you think it makes an impact on the system?
Yeah, so our training's mandatory, and there's been loads of work done actually by GIRFT, and there's a lovely paper by Amy Bain and Sally Ann Kavanagh that tells you if you train well and if you have a pharmacist involved in diabetes care, those trusts have less errors. It's across the board. So our training, we have education for our F1s and our F2s very start of the year, where their second training slot, because we know how high risk insulin is, so where their second training slot, it's all recorded, and they need to attend a mandatory 80%, but we ask that they must attend or listen to the recording on the insulin prescribing. I train all our pharmacists, so all our pharmacists get training. All our nurse preceptors get training when they start. All our nurses get training when they start. What we need to do is make sure that we then catch people again, because catching you once when you start in a trust, when you then work there for 20 years, is not robust. So I think we've got it right at the start. We haven't got it right all the way through, and it's making sure you make the most of ad hoc opportunities like Insulin Safety Week, and we use that as a way of going around and catching our staff, especially front of house. You can do really quick 10-minute training, do it at the handovers, do it a couple of times a day, and you can catch a humongous amount of staff. So we trained 300 staff in our organisation on Insulin Safety Week last week really quickly without a huge amount of time either. So that would be my tip.
Okay, and then someone asked about self-managed pumps, so patients with their own personal pumps. How do you at Gateshead input that into your e-prescribing system?
So all our pump patients are started on pumps and managed on pumps by us. So when that happens, part of the process is I add a note onto their electronic prescribing record, which means the minute they come into hospital, we get an alert that they are in hospital. So that alert flags to the pharmacy team. And we also get an email direct to the diabetes team that all of our pump patients are in. So that's the first thing, is knowing the person's in the hospital is really important, because if we know they're in, we can go and see them, we can make sure it's safe. We use placeholders quite a bit at the minute for our pumps, so more to show that the pump is on, the pump is running, that the person knows the pump is running. It's a check for the nursing staff that that pump is running. Again, not perfect, I will freely admit that. So we have a placeholder for the insulin, so we know what insulin is running in that pump, and a placeholder for the pump, but we have alerts on the system that that person is there as well, which is really important. And we also get an alert if their blood sugar's not checked to an amount we feel it should be as well. So that's another safety net in the process.
Okay. So you have prompts for your nursing staff as well as your medical staff in?
Yeah, so prompt. I'd have to check it, but I think it's 4 times a day to say, will you check this pump's running first thing in the morning, lunchtime, evening and night.
Okay. And is that come as like a dummy drug on the Sky? Yeah,
exactly, like a dummy drug. And we also will, most places probably have the same thing. We teach our nursing staff, please do not touch the pump unless you're a diabetes specialist. Please do not touch the pump, let it run. So that is there to say, check with this patient that pump is running, they are happy with their pump management, and if not, contact the diabetes team, and that is all on the system.
Okay. All right then, Claire, thank you. I think I'm going to ask more questions about the ISN because I think some people are asking. So I might ask Rob a couple of questions if he wants to come on. So one person, Max, has given us a question about the standard and states the use of dose-based prescribing in secondary care as long as you take in data and send it back out to GPs in a product-based format. Is our NHSX working on a practical solution for this translation of these between standard states, between dose-based and product prescribing? I think that's the question.
I'm going to answer, Steph, if I can. I can't substitute for Rob, unfortunately, but because his computer's still not working, you'll have to make do with me. I'm sorry. So the answer to that is yes. Those syntax work absolutely allows the translation between product and dose-based prescribing, and has been designed absolutely to allow that to happen. Clearly, at best, it can give you options when moving from dose to product, but it will limit the options so that you've only got 2 or 3 to choose from according to whatever's being prescribed. So the answer to that is yes, it's absolutely designed to support that. Next one, Steph.
Me. Go-to's having a mare with me. I'm having a mare.
Okay, right. Let me see what else we've got in the questions. Secondary care, Max, you've asked about, don't care about brand names, so just use VMP codes. That's absolutely fine. And the way that the secondary care guidance for DM&D works will allow you to use actually both, so you can use both the product and the brand name if that's helpful and that's what you want to do. So if you look at the secondary care implementation guidance for things like morphine and so on, then yes, absolutely you can do that. I won't answer the question.
There's a question about support from the centre and to help deliver this within local trusts.
So absolutely, Dan, there is a team. The medicines interoperability team is there to support. There is support just from the likes of Rob in terms of technical input. We've also provided other bits and pieces of support for people, depending upon where they're up to in their journey. So get in touch if there are things that particularly you want to ask. We can't do the job for you, clearly, but we can help support and answer any questions. And if you hit any problems, either point you towards other people who've already resolved those and overcome them, or if there are challenges that nobody's come across before, we'll help you work through them and then share that learning with everybody else as well. So I absolutely can do that. So just come and talk to us. Okay, if you haven't, I was going to say, if you haven't heard of the ISN, then please do go and have a look. It's really important because all trusts will be required to be compliant with it. So if you've not looked, it's a statutory requirement by March 2023. So please do go and have a look. Question about the MSO network with VT risk assessment linking. Can we catch up? Yes, Joy, I'm really happy to do that. That's not a problem. So Stephanie, I think we've answered the questions. Let's go back to you just to round off, I think.
Yeah. Sorry about that. GoTo's having issues with me and wants to kick me out at every opportunity. Thank you, Anne, for stepping in. I just want to say thank you to everybody who's participated over the past year with the ePrescribing Masterclass, whether being a speaker or asking questions or just being an attendee. We appreciate it, especially at this time and with the NHS being at level 4. Thank you for coming and attending for today. The slides will be available for everyone after this presentation. So even though we've had technical problems from Rob and myself, and the slides for all the presentations and from Claire's presentation will be available for everybody. There won't be a masterclass next month. So the next masterclass is on the 9th of February, and that will be a collaboration between ourselves and also looking at medicine safety as well. So please join, and please tell your colleagues and anybody else to come and join next year. It's on the 9th of February at 1 o'clock at the same time. Yes, we just want to say thank you to everybody, and thank you for bearing with us during our technical difficulties. And if anybody does want to present next year or and want to present a project, please feel free to. So you can contact me, or you can contact Sarah Black at the AHSN and just give us your details, and we can get you to present it at some point next year. But overall, I just want to say thank you to everyone, and thank you to Anne especially as well, and for helping us facilitate. And thank you to Sarah for facilitating today. Okay, thank you everyone. Bye.